Hey everyone, and welcome. Today, we're going to dive into something that is absolutely critical in the clinic: how to take a really solid, comprehensive history from a patient with chronic diabetes. My goal here is that by the time we're done, you'll have a powerful, step-by-step framework that makes sure you cover all the bases, every single time. So, picture this. A patient with a long history of diabetes is sitting in front of you. It can feel like, wow, where do you even start, right? There's just so much ground to cover. But here's the thing. The key isn't trying to remember a million different things at once. It's all about having a roadmap, a system. So, let's start at the very beginning.
First things first, before we get into all the nitty-gritty clinical details, we just need to hear their story. And I want to be clear, this isn't just about ticking boxes or writing down dates. It's about understanding their personal journey with this condition right from day one. That context is going to frame everything else we talk about.
Think of these 4 questions as the prologue to their entire diabetes journey, their origin story, if you will. When gives you the timeline. Have they been dealing with this for 5 years or 50? How tells you a ton. Was it just a random finding on a routine blood test, or was it a dramatic, full-blown emergency? And finding out the initial treatment and whether they were hospitalized gives you an immediate sense of the severity right from the get-go.
Now, for a patient on insulin, you got to become a bit of a detective, because every little detail is a clue. Who actually gives the injection? Is it them, a spouse, a caregiver? That tells you so much about their independence and their support system at home. Are they rotating their injection sites? I mean, if they're not, their skin can get lumpy, and that can totally mess with how the insulin gets absorbed. And do they keep a blood sugar diary? That shows you right away how engaged they are with their own care. Even asking how they store their insulin is huge. Is it even going to be effective when they use it?
Okay, so once we have that backstory, we need to slam on the brakes and focus on the right now. We have to immediately scan for any acute present dangers. This is all about patient safety, first and foremost.
And really, we're on the lookout for 2 big, scary things: diabetic ketoacidosis, or DKA, and hypoglycemia. And you have to be super direct about this. For DKA, you're asking about things like tummy pain, vomiting, or just feeling really unwell. For hypoglycemia, or low blood sugar, the classic questions are about shivering or sweating. These are absolute red flag symptoms you can't afford to miss.
Now, if a patient tells you they get hypos, you can't just stop there. We have to dig deeper. It's not enough to know it happens. We need to know if they're even aware of it. Like, can you actually feel when your sugar is dropping? What's your game plan to fix it? And this is critical. Has anyone ever taught you the sick day rules for what to do when you get a cold or the flu? This is all about being prepared so a small problem doesn't turn into a huge emergency. All right, so we've put out any immediate fires. Now, we can pull back and look at the bigger picture. It's time for our methodical, head-to-toe scan for the long-term complications of diabetes. This is our system review, where we're looking for those subtle, chronic ways the disease can affect the whole body.
We'll get the ball rolling with the nervous system. You see, over a long period of time, high blood sugar can really do a number on the delicate nerves all over the body. It's a condition called neuropathy, and we need to be actively looking for it.
And honestly, the best way to screen for this is with 3 super simple, direct questions. Have you noticed any weakness anywhere? Any numbness? Or any tingling sensations, maybe like pins and needles? These symptoms usually pop up in the hands and feet first, so asking about them directly is a really effective way to catch early nerve damage. Okay, next up, let's move to the body's engine room, the heart and lungs. We know that diabetes dramatically increases cardiovascular risk, so this check, it's absolutely non-negotiable.
So the questions here are kind of two-pronged. First, we check on their monitoring. When was your last ECG? Are you checking your blood pressure regularly? This tells us about their preventative care. And second, we screen for any active symptoms. Are you getting a lot of chest infections? Any shortness of breath? These could be clues to underlying heart or lung issues that are tied to their diabetes.
Now, let's group a few things together that are often connected. We're going to check on the eyes, the gastrointestinal system, and also screen for a few other autoimmune conditions that sometimes like to hang out with type 1 diabetes.
This table is a great way to think about it. We're using specific questions as keys to unlock potential related conditions. You ask a simple question like, any blurring of your vision? And immediately, you're thinking about retinopathy. You ask about feeling too hot or too cold all the time, and that could be a sign of thyroid disease. Craving salty foods? Yeah, it's rare, but that's the classic textbook question for Addison's disease. And tummy troubles like diarrhea could even point towards celiac disease. Each question is a targeted probe.
Let's round out our system check with one of the body's most important filters, the kidneys. Kidney damage or diabetic nephropathy is a huge long-term complication, so screening for it is essential.
And yes, we're talking about blood pressure again. It's that important for kidney health, because high blood pressure just puts them into overdrive. Then we ask about their habits. What's the amount and color of your urine like? Are you having to get up in the middle of the night to go to the bathroom? These are really simple things to ask, but they give you huge clues about how well those kidneys are doing their job.
Okay, we have covered all of the core medical checks. But a patient, they're not just a collection of symptoms. Now we have to zoom out and understand the person who is living with the diabetes.
Because here's the reality. You can have the best medicine in the world, but good diabetes management doesn't just come from a bottle. It's really built on 4 essential pillars: diet, exercise, their clinical care team, and their social history. And if one of those pillars is shaky, the whole thing can start to wobble.
So what does this mean in practice? It means getting into the real-world stuff. For their diet, what does a normal day of eating look like? For exercise, what are they actually doing? Are they going to their specialist appointments? And please, whatever you do, do not skip the social history. Who do they live with? What do they do for work? All of these things had a massive impact on their ability to manage this condition day in and day out.
All right, we are almost there. We just have a couple of final, really essential questions to ask that will tie this whole picture together.
This is so important. For anyone who's had diabetes for a long time, you have to ask about their worst days. How many times have you been hospitalized for DKA? Were you so sick you had to be in the ICU? Hearing about those times gives you this incredible insight into the overall trajectory of their disease and just how fragile their control can be.
And now for the final check. It's so simple you might forget it, but it could literally save their life. Do you wear a medical alert bracelet? Think about it. In an emergency, if they can't speak for themselves, that one little piece of jewelry changes everything for the first responders. It's a simple, practical question that brings us full circle. Back to our main goal here, which is providing thoughtful, thorough, and safe care. And by following this kind of framework, you can be confident that's exactly what you're doing.